Hello, this is the first video for the infertility lecture for 602. So this is going to be the first lecture that is on your next exam. Into the past lectures, review the resources that are posted on UB Learns. The infertility packet in cases workbook will really be your guide for what to study for the exam. There are additional readings posted on infertility topics. The most useful one is probably the article in JAFA, which really talks about the pharmacist's role in treatment of infertility, so I highlighted that one under the additional readings and topics. But really the testable material and what you want to know is that it's in the infertility packet and workbook. So if you scroll to the beginning, the objectives are the ones listed on UB Learns to know how to discuss the process of normal fertilization and what the definitions of infertility are and things that might contribute to an increased risk of infertility, to really be able to understand some of the key elements in the emotional components of infertility and OTC infertility medications and how to counsel or tests and how to counsel patients on those. And then to recall the different medications, how they work, their side effects and counseling points as it relates to infertility in general, and then specifically endometriosis and PCOS, and then recommend medications for pharmacologic management of infertility given a patient case. So if you scroll to the background, infertility is something that seems to be increasing. It has a couple definitions. It's considered the inability to conceive a child after at least 1 year of frequent contraceptive-free intercourse. So that's important when you're taking a patient history, is to ask how long have they been trying and when was the last time they used contraceptives. This would be important, especially for certain contraceptives such as the Depo-Provera shot. If they'd been trying for 12 months, but the woman had received a shot within the previous 18-month time period, that could be the reason that they weren't able to conceive. If a woman is greater than 35 years old, this time period drops down to 6 months, and that's because we really want to have them evaluated a little bit sooner so that any problems can be addressed in a faster time period. So if you review this chart, the likelihood of getting pregnant significantly decreases as a woman ages, and the likelihood of infertility is inversely proportional. So as a woman ages, their ability to have a baby after the age of 35 is extremely decreased and decreases even faster after the age of 40. You can see that the line has a much steeper slope then. And then miscarriage rates are much higher as women age as well. Also important to remember that each month a patient only has about a 20 to 25% chance of conceiving, and that 1 in 10 couples will experience infertility as they embark on their journey for children. This increase in infertility that we've seen over the past 10 years or so has been loosely related to a delay in trying to have children until patients are of an older age due to finishing schooling or finishing training. Your peak fertility is in your early 20s, but a lot of patients don't want to have children until they're a little bit older and more established, and this might be why we're seeing increases in infertility rates. So we talked about what infertility is. The other thing to consider is whether or not it's primary or secondary. So primary is the couple has never conceived a child, and secondary infertility is that they already have one child or a prior conception with a subsequent inability to conceive again. So there are a number of different things that have to go correctly in order for normal fertilization to occur. So with going along with that 20 to 25 chance per month of conceiving, all of these things have to be working and in the correct order in order for someone to conceive. So you have to have an appropriate amount of normal sperm, a normal quantity, a normal quality, and usually in evaluations of fertility, sperm quantity and quality is tested first because this is a bit easier than the testing that a woman has to undergo and much less invasive. The timing has to occur around the time of the mature oocyte being released. So if we think back to our normal menstrual cycle, when the LH surge occurs, ovulation will follow in the next 24 to 48 hours. And that's the time when couples should be counseled to attempt to conceive. So timing is important. The mature oocyte won't be released if the hormones, estrogen doesn't reach its appropriate peak, or if LH is not released due to some other reason. So timing is important in order to have the egg be released, as well as have it be around for when sperm can come in contact with it. So they also have to have a normal ovulation cycle, so a sufficient amount of estrogen to trigger an LH surge, or a sufficient amount of progesterone in the latter half of the cycle in order to maintain an appropriate endometrium for implantation. Then the oviducts or the fallopian tubes have to be patent to allow for fertilization and transport. Things such as sexually transmitted infections and pelvic inflammatory disease, so chlamydia, gonorrhea, these things can lead to scarring of the oviduct and fallopian tubes and increase the risk of infertility. And then finally, we have the uterus has to be able to support implantation. So the endometrial lining has to be of an appropriate thickness and be able to support implantation. All uteruses are not, made the same. Some have alterations in them that make it more difficult for a fertilized egg to implant due to physical or structural abnormalities. Causes of infertility are numerous. Some common ones are listed here. There are male factor and female factor causes of infertility. So endocrine abnormalities, anatomic abnormalities, sexual dysfunction can lead to male factor infertility. Female factor, there are a number of things that can be evaluated. So ovulatory dysfunction in things such as PCOS or polycystic ovary syndrome, cervical issues, or tubal, uterine, or peritoneal disease due to things such as pelvic inflammatory disease. Some of the medical conditions in women that can lead to infertility are listed there, and we'll go into those in more depth, some of those in more depth at the end. First step would be counseling patients on the non-pharmacologic management of infertility. Patients can be counseled on having a healthy diet, so protein, lean protein, fruits, vegetables. A healthy diet has been shown to improve fertility. Men having an appropriate supplementation of zinc, as zinc deficiency has been associated with sperm issues and leading to infertility, so supplementation of zinc. An appropriate amount of exercise, so not too much or not too little, as too much can lead to amenorrhea, as we learned in the menstrual cycle disorders. Weight loss and weight gain. The best weight is a BMI that is normal, so 24 to 30, or within 15% of an ideal body weight. Fertility decreases for those where their body weight is either below this or above their ideal body weight. So an appropriate weight. Cessation of smoking is a counseling point for a number of reasons, but it can also improve fertility. And then we can also review a patient's profile to see if there are any medications associated with infertility on their profile. Some things can be stopped or switched to alternate agents, and some things might not be able to be. I've listed all of those there, so if you're given a patient profile, you would want to make sure that you review it for any medications that can impair fertility, either due to increases in prolactin that can inhibit fertility or impaired spermatogenesis, specifically in male patients. And then additionally, in non-pharmacologic management of infertility are assisted reproductive technologies such as IVF, intrauterine insemination and implantation of an egg that has been fertilized outside the woman's body. All of those fall under non-pharmacologic recommendations. And since those are a little bit out of the scope of pharmacy, we're not going to go into those in too much detail. Predicting ovulation. So all these types of kits are available over the counter and can be easily purchased online. You can purchase them on Amazon. So patients might come to the pharmacy asking how they can help predict ovulation and improve their chances of conceiving and improve their fertility. So basal body temperature and ovulation predictor kits are both available. I personally usually recommend the ovulation predictor kits for patients because basal body temperature is a little bit more time intensive and has about a month delay until you can find out when you might be ovulating. So how does it work? So for a basal body temperature measurement, you have to have a specific basal body temperature thermometer, and it's something that has 2 decimals after, so it would be like 98.62, because you need an extremely sensitive measurement in order to see changes. So what happens in the cycle is that in the latter half of the cycle, progesterone can cause an increase in basal body temperature. So in the early part of the cycle, estrogen causes a decrease in basal body temperature, and then progesterone, as it begins to be released by the corpus luteum that's surrounding the egg after ovulation, begins to secrete progesterone and increases body temperature. And you can test for that increase in body temperature and then look back to find that increase. The increase is usually about 0.5 degrees Fahrenheit, and if you see the increase in temperature, as you can see in the chart, if there's a small increase in temperature, then you know that ovulation has occurred and you're in the second half of the cycle. So the way that patients would do this is that they would have a thermometer, they should place it at their bedside at night, and they should be testing first thing in the morning before they get up, before they get out of bed, before they put their glasses on or take a drink of water, and they should be doing it at the same time every day. They usually start on day 1 of the cycle, which again, as a reminder, is the first day of menses, and then they chart anything that might cause alterations in their temperature, such as illness or intercourse, any medications, excessive exercise, and then they would use a little chart. You can use apps for this in order to find this small increase in body temperature. So you would do this for a month. So you would do it daily for a month and then look back on the chart to find out when the increase in body temperature occurred and mark whatever that day is. So day 14, day 17, and you would know when ovulation usually occurs for that woman. Then you can predict when to counsel the patient to have intercourse based on that timing. So if you know that the woman usually ovulates around day 17, that's the time when you should be counseling the patient that they should be having intercourse. So it's a little bit of a delay, about a month delay, until the patient can use this information. For a little bit faster, patients can get LH predictor kits, and basically it's looking for, and it will detect LH in the urine, and it's the surge that's occurring prior to ovulation. So patients should start testing. It can either look just like a pregnancy test where they just dip it in a cup of urine or insert it midstream. And then they start testing 3 to 4 days prior to their expected ovulation date. So if they expect to ovulate on day 14, they should start testing around day 10. And check daily until they see the color change. So it'll look just like a pregnancy test where, another line appears, or there are some that are more sophisticated that might have additional information. But they'll keep going until they see that color change. And then that's when they know that LH has been released and that ovulation will occur in 24 to 48 hours after that color change. So they should be counseled to have sexual intercourse 24 to 48 hours after the color change is detected. So this can be done, immediately in the first month of self-monitoring. And so I feel like it's a little bit faster for patients. Again, this can be, purchased at a pharmacy or on Amazon, online. So it's pretty quick.